Hello, my name is Chris Oliver and I'm Chief Executive at Lancashire and South Cumbria Foundation Trust. And welcome back to the third podcast in our series of In Conversation with a CEO, which hopefully will provide listeners with an insight into the services provided by the Trust. It's great today to be joined by Becky, who is our consultant clinical psychologist. And today we're going to be talking about borderline personality disorder. So, hi Becky, it's great to be joined with you today.
Hi, thanks very much for having me.
So, as I've mentioned, we're going to talk about borderline personality disorder, which I know is something that you're really passionate about.
Yeah, absolutely.
And it's also really timely this month because it's dedicated to raising awareness of the condition.
It is, yes. May's Borderline Personality Disorder Awareness Month, both nationally and internationally as well. And I feel really passionate. I'm so pleased that the Trust is kind of recognising that in a podcast today. So thank you for the opportunity.
No problem at all. Well, let's get started. What is personality disorder?
So I'll tell you a bit about myself. So I'm a consultant clinical psychologist. My roles within the Personality Disorder Managed Clinical Network, a snappy title, or otherwise known as PDMCN. And I'm also the kind of clinical lead of that service and work within that. So we're based often with the adult services and CMHTs. And a lot of our work is about sort of bringing awareness and treatment to this client group, which we feel really sort of passionate about and really pleased with the work that goes on. I can't wait to tell you all about it. I first came to the Trust actually in 2007 as a trainee clinical psychologist. So I've been with this Trust for about 16 years or so now in various different guises. I started off in the forensic services, working at Guild Lodge. I've worked in home treatment teams and then worked my way through to the PDMCN Personality Disorder Clinical Network. And part of that was really my passion about wanting to work with people who have really complex, really distressing difficulties and an opportunity to really make a difference to that client group. And so it's really been my passion for the last kind of 10 years or so working in that team. And there's such great work going on in the Trust.
That's fantastic to hear, Becky. And can you tell us a bit more about what borderline personality disorder is?
Absolutely, yeah. So I think often it's helpful to just think about what is personality first. So personality is a kind of the way that we think, the way we feel, the way we interact with the world. And we all have that. It's kind of who we are. And for people who might attract a diagnosis of borderline personality disorder, the same things apply. However, they might have difficulties in those different areas. So difficulties with the way that they think and get stuck in certain ways of thinking, in the way that they feel their emotions. So they find them really difficult to manage and experience them very intensely and much more than we might do. And also in their relationships and how they interact with other people, it causes them great difficulties and great distress in terms of that. So those are kind of some of the areas of difficulty. So it's emotions, relationships, thoughts, and often a much more propensity to be impulsive.
Okay.
And people can feel that from kind of a mild, so it might be a mild difficulty in certain areas, all the way up on a spectrum, really, to the more sort of significant or severe difficulties. And really, it's just a collection of symptoms, a collection of difficulties, which is kind of given a diagnostic label. So some of those things are fear of abandonment, self-harming or suicidal behaviour. It might be sort of chronic feelings of emptiness, impulsivity, explosive anger. So some really difficult collection of experiences, which is kind of given that label or diagnosis of borderline personality disorder. I think just for the listeners, it's really important to note as well that often within the Trust and nationwide, it is given different names as well. Okay. So there's emotionally unstable personality disorder. That's the ICD version of the difficulties. And more recently, especially within a lot of the NHS long-term plan paperwork and in the Trust in general and the personality disorder staff in general, it's often thought of as a complex emotional and relational needs. So if you hear any of those terms, they all kind of are describing the same sort of thing in terms of those difficulties in those kind of key areas for people.
That's great to hear. Thank you. And I'm sure I'm not alone in thinking that over the years, there must have been many misconceptions or stereotypes about borderline personality disorder.
Yeah.
Can you just talk through about, I suppose, how we've changed and how the services have changed over that time?
Yeah, absolutely. So, yeah, you're quite right, Chris. It's in some ways for the services and for service users, it can be quite a controversial diagnosis or label to sort of have attached to them. So, For some people that I've worked with, they find it kind of helpful and validating, like, oh, now I know what it is that I'm experiencing. It isn't just a me thing. This is a real kind of difficulty that people have, and now as a treatment pathway. However, for other people, it can be, they can see it as particularly unhelpful and potentially result in further stigmatization. So there is a lot of controversy around about it. And often for staff members working in LSCFT, people who attract this diagnosis might present with quite scary behaviours in terms of sort of self-harming or wanting to end their lives. And that in us makes our anxiety rise. And often then we only see the tip of the iceberg, potentially what the person is presenting with, rather than the full story. Now, that's not an LSCFT problem. That's an everywhere kind of problem. So some of the misconceptions that people might have is that service users who might attract this diagnosis maybe being manipulative or attention seeking, or it's just behaviour, etc. So there can be a lot of different and maybe on the more negative side ways of describing it. And so what I'm really pleased about this podcast really, and the kind of work that LSCFT are doing in terms of raising awareness, is this is a real passion of mine to help people understand and know a little bit more, because this isn't them having a particular negative view of the world. This is, taking things on face value, as we all do quite often. But I think what's really important for people to think about is to take a step back and see the whole of the iceberg. What is it that's going on below the surface, and the reasons why somebody might be acting in a certain way. And rather than attention seeking, potentially what people are doing is connection seeking. Rather than manipulating, what they're doing is they're unable to understand what's going on in someone else's mind due to the experiences and difficulties they've had. So they're acting in a way to try and get their needs met. It's basically they have maybe a smaller toolkit than other people do.
Okay.
And they use what they have at their disposal, I suppose, to try and get their needs met. And that can result in a lot of very tricky, challenging situations and scary behaviours for people. But ultimately what they're experiencing is kind of unbearable emotional pain often, and using what they've got to kind of manage that. I like the, I think it's called an analogy. I like the analogy of, you might, I don't know if are you green fingered, Chris? Do you like gardening?
I do.
Yeah. So, if you planted a flower, and it didn't flourish in the way that you might wanted it to, there would be multiple different reasons why we might think that would happen. It could be the wrong soil. I might not have watered it enough. It maybe needed some plant food. There could have been an infestation of slugs, etc. There could have been multiple different reasons. And I like to invite people to think about borderline personality disorder a little bit like that, in terms of we wouldn't blame the flower and say the flower isn't working hard enough or it's doing it on purpose. Really, we need to look at what are the factors, what are the influences that are preventing this person from flourishing and having a life worth living, really.
That's really good. Really insightful. Thanks, Becky. And Becky, is there a cause of borderline personality disorder, or is it multifactorial sometimes?
Yeah, absolutely multifactorial. So there's no one cause, as is often the case with many mental health problems. But what the kind of research and information that's out there suggests is that it's a combination of two main things, really. So the first being somebody might be born with more of a genetic biological predisposition to certain ways of being. So I'm sure you'll know yourself, when you meet two babies, no two babies are the same. There's different temperamental differences. Some might be a little bit more cautious, others might be more impulsive and, jump off the wall that someone else would never dream of doing, etc. So there may be a kind of a predisposition potentially for more sort of impulsive type behaviours. And that in combination with a kind of environmental experiences. So we're talking about real kind of chronic invalidation of someone's emotional experiences, it coupled with often trauma, abuse, stresses, multiple distresses. And for people to usually attract this diagnosis, that usually has to have happened in multiple different parts of their life, in multiple relationships. So ultimately, these people have been through a lot of trauma quite often. And that in combination throughout their kind of childhood adversity and throughout their lives kind of causes the sorts of difficulties that we might describe. So one thing I like to think about is, as a child, we're completely vulnerable and reliant upon everyone around us to kind of look after us and keep us safe. So if you imagine a child scared, something's frightened them, in a kind of a helpful, healthy emotional environment, they might go to a caregiver and they'll be like, oh gosh, are you okay? Do you need support? Yeah, that is scary. If they feel heard and they feel understood, and that helps someone call what we call mentalize. They feel that someone else has got a picture of them in their mind. And then another child who has the same experience but has either no one to go to, so feels very on their own with that, or when they express that might be met with kind of negative reaction or further trauma or further fear. People or children have to deal with that in the best way that they know how, and often that is quite internalized.
Yeah.
So that's how they kind of end up finding the best way they can manage, which is often can be sadly unhelpful ways. So I think in essence we're kind of all susceptible.
Okay.
And if we've not developed difficulties associated with this diagnosis, then we're lucky, and we've likely had some good attachments in our lives.
Brilliant. Thank you. Really well explained. And how many people would be living with this condition?
Yeah, so there's wide variety if you look at the research. However, the kind of more recent stuff suggests that it's approximately 1.6 of the general population, rising up to 20% plus if you go into an inpatient setting. So I looked up the population of Lancashire and South Cumbria, and I believe there's about 1.8 million.
It is, yeah.
So in our region, in Lancashire and South Cumbria, you're looking at a conservative and a very conservative estimate of about 30,000 people that might live with this diagnosis. And now, obviously, they're not all going to kind of come in contact with our services, as they'll be experiencing it in different levels from mild to severe, and some may have, really good support mechanisms in place, etc. But it's certainly something that affects a large proportion of our service users. And
taking that on board, Becky, what can we do as an organisation to support people with borderline personality disorder?
Yeah, it's a great question. So there's loads of things that we can do, really. And the message I really want to get out to the listeners is that there is lots you can do. Please be hopeful, and recovery is possible. And I think often that can feel quite far away, for people, but it absolutely is. I've seen it happen, and it's fabulous when it does. So you can help and you can make a difference. And I think some of the more general ways that we can help is, the iceberg I was talking about earlier. So really taking that step back, rather than being absorbed by what is the behaviour that I'm seeing. It's not what's wrong with you. It's more like what's happened to you to kind of cause it. What's the function? What's going on behind it? Take time to listen and really try and understand. So often we might feel so anxious by what a person's presenting with. We don't do that, or we're in a really busy, fast-paced environment where that's really difficult. But really listening and trying to understand. And my key top tip would be validation.
Okay.
So when speaking with someone who might be distressed in this way or might attract this kind of diagnosis, find the valid parts of what they're describing, and validate that as much as you possibly can. So, for example, I might not validate that somebody wants to end their life, because obviously that would be a tragedy that we would absolutely not want to happen. But what I can validate is that distress that you're feeling and the reasons why you feel that distress. And what that is doing is creating that kind of connection of some sort of level of attachment, that you see me, you hear me, you understand what I'm going through. And that in itself can actually be soothing for people. Because often what people want to do is solve the problem straight away. We're problem solvers as human beings, aren't we? We want to get something sorted, and I want to help this person and say the right specific golden nugget word.
Yeah.
And often that isn't the case. And that's really difficult for us, especially as caring staff, to come to terms with often, because we want to make something better for someone straight away. That's why we come into the job. But yeah, my kind of key message would be really to just sit with and understand and try and really experience what that person's going through. Drop any kind of defensive stance that we all have from time to time. And if you're able to, be really consistent and reliable. Because what we know is that if so often we advocate for kind of appointments, same time, same place each week, so that we're offering a kind of a scaffolding, really. So these people who might present with these diagnoses or these difficulties often have no kind of sense of consistency and don't trust people, don't feel like they're going to stick to what they're saying, understand it because of what they've been through. So if we can be as consistent and reliable as we possibly can, that can really help to scaffold them and build a level of trust between us. And I guess what another kind of top tip, which is try to avoid kind of generalized statements that might be experienced as dismissive. So an example, which is a very British thing, we all love it, is, make yourself a cup of tea, or, go and have a minute, go and have a bath, those sorts of things, which are meant with a really, really wonderful intention of trying to help somebody soothe. But often what that can do is, if we've not done the hearing and the listening and the validating and the understanding part, it can be experienced as dismissive. You're not listening. I don't want a cup of tea right now.
Yeah.
What I'm trying to tell you is that I feel so unbearably distressed that I can't cope. And also often the good bit of the cup of tea is that someone makes it for you, and it's kind of a caring gesture. It's an attachment thing.
Yeah.
So I'd say try and hold back from making those, unless you know the person really, really well and you know that's a helpful thing. And just try and scaffold them, think through, if you were in that situation, what would you do? It's ultimately they're people that are experiencing ultimately horrendous distress. And if we're able to just sit and be with them, that can be so, so helpful. And I suppose the other option, if someone's in the right kind of place, right time, considering with them some of the NICE guidelines, recommended treatments can be a helpful thing. It's not for everyone at that particular time potentially, but for some people it can be a really helpful thing as well.
Perfect. And it was really important there, Becky, when you talked about recovery and that hope. That's really important, isn't it?
Absolutely. If we can hold on to that when the service user can't, and or in that moment they can't, I think that's really important, because often they can't see the light at the end of the tunnel, and we have to hold that for them as much as we possibly can. Yeah.
Brilliant. So could you just talk to me a bit about our own borderline personality disorder service and what we provide as an organisation?
Yeah, absolutely. So clients who might attract this diagnosis will hit multiple parts of our services. Okay. So, A&E, urgent care pathways, acute therapy service, ATS, CMHT. So
CMHTs would be community mental health.
Community mental health teams, yeah. Sorry, we love our acronyms, don't we? Yeah. So they'll hit multiple parts. So good work and helpful work can be done in all of those different areas. They really can. However, the NICE guidelines and not the evidence base suggest that longer term psychological work is the most helpful for this client group, which makes sense given that often their difficulties and their experiences from the past have been over such a long period of time that this isn't something that's solved, overnight potentially. So from us in the Personalised Disorder Managed Clinical Network, which is kind of based alongside the community mental health teams, we have various different NICE guidelines therapies available. So we've got something called structured clinical management, which is a 2-year treatment where people can see a worker once a week at the same time, same place. And then once they've kind of got into that, they can join a group as well. And that sort of lasts for 2 years. And it's basically based on problem solving. Okay. Helping somebody learn new coping skills, helping them solve the problems in the moment, helping them bring down the distress when they're up here and feeling like they can't cope. And that is available within general CMHTs and with ourselves in the Personalised Disorder Network. There's something called dialectical behaviour therapy, which we have 4 different consults, one set up in each of the networks in LSCFT. And that is, again, an 18-month therapy, which is very much focused on working on self-harming behaviour and suicidal behaviour and bringing that down. And I'm a part of that, and I'm a real big advocate for this intervention. I think it's fabulous if people are at the right place when they get it. And we've seen some great results of people going from really quite significant self-harming to being working, living a great life. Yeah, I just got a message recently from someone who just got a part-time job, which she never thought would be possible in a million years, a couple of years ago. So some great stuff going on there. And we also have mentalisation-based therapy, which is, again, an 18-month-long therapy involving group and individual therapy. And that is talking about that attachment stuff I was thinking about. So helping people develop a picture of what might be going on in someone else's mind and working on that. So there's lots of kind of great stuff going on. There really is. And there can be some useful shorter term work done as well. If you can help people with coping skills, problem solving skills, managing emotions, getting through a crisis successfully. building up their occupation, social life, building a life worth living. That's what we want for people, building their peer support networks. All those are so valuable. And if they can work alongside a kind of a therapy, then they can really make a massive difference for people. I also want to do a little shout out about the personality disorder best practice group. So that's a very recent group that's been kind of set up. And if staff are interested in getting involved in working with personality disorder and what the kind of best practices are, then we'd love to hear from you. So please do get in touch with me, because we're always looking for kind of advocates and people who feel passionately about this service user group.
Fantastic. And that you just mentioned about wanting people that are passionate about this service, and your passion for borderline personality disorder and our services and our service users is just fantastic, Becky. So, we are so lucky to have you working with us within the Trust. So I just want a massive thank you for simplifying what can be, I thought originally, a really complex topic, but you've really distilled the various spectrum of it and how there really is recovery and hope. And that's so important. So I've really enjoyed talking to you today, and I'm sure our listeners have. So just a massive thank you.
Oh, thank you for having me. Thank you very much.
Take care.
Thank you.